Welcome to webinar 2. We will get started shortly. We'll give everyone a few minutes to log in. But while we're waiting, feel free to click on your resources tab at the bottom of your screen and download your workbook. We'll be using this for today's session. Also, while we're waiting, let us know where you're joining from in the chat. Welcome to webinar 2. I see a few of you all are joining. We'll get started shortly. We'll give everyone a few minutes to log in, and while we're waiting, feel free to click on your resource tab at the bottom of your screen and download your workbook. We'll be using this during our session today, and while we're waiting, let us know where you're joining from in the chat. Welcome to webinar 2. We'll be getting started shortly. We'll give everyone a few minutes to log in, and while we're waiting, feel free to click on your resource tab at the bottom of your screen and download your workbook. We'll be using this during our session today, and while we're waiting, let us know where you're joining from in the chat. Welcome to webinar 2. We'll get started shortly. We're giving everyone a few minutes to log in, but while we're waiting, feel free to click on your resource tab at the bottom of your screen and download your workbook. We'll be using this during today's session. Let us know where you're joining from in the chat while we wait. All right, we'll go ahead and get started. It is 12:03. Good morning or good afternoon, everyone, depending on your time zone. Welcome to the National Network of Public Health Institute's 4-part webinar series. So welcome to session 2, Healthcare Inequities and IPC, Infection Prevention and Control. I'll share more about the upcoming webinar today shortly, but to start, my name is Nia Smart and I'll be your facilitator for today's session. Your trainer for today's session will be Karina Kelly. And again, my name is Nia Smart. I'm your facilitator for today's webinar, and I also serve as the principal consultant and founder of Smart Public Health Consulting. So as a passionate public health practitioner, I established Smart Public Health Consulting to support organizations with strategic solutions and health education, facilitation support, project management, and community outreach. My experience spans over federal, state, and local levels where I've led large-scale public health initiatives. I've also served as the vaccine program manager and led projects related to COVID-19 response, infectious disease prevention, and community outreach and education. My work also includes a strong focus on health literacy initiatives, ensuring communities have access to clear and actionable health information. Over the past year, I've also found myself deeply involved in workforce development. So as more students, recent graduates, and universities have reached out for guidance, I've been committed to sharing cutting-edge tools and strategies to help navigate their careers in public health. I'm also excited to continue supporting the next generation of public health professionals and increasing health education and literacy. Now to Karina, would you like to introduce yourself?
Yes, absolutely. Welcome, everyone. Thank you for joining us today and for your dedication to advancing healthcare equity, patient safety, as well as improving population health for all. It is really reassuring to know that we are not alone in these efforts, and together, by strengthening our networks and fostering meaningful connections with our colleagues and communities, we can successfully navigate challenges and drive positive change. My name is Karina Kelly, and I'm honored to have served in public health for over 20 years. I really come from a rich and diverse background as a half Black, half Mexican woman with Indigenous Native American roots from Southeast Texas. As a founder and CEO of Creed Consulting LLC, a minority woman and disabled veteran owned organization, our mission is to empower individuals and organizations to build resilience, to navigate change, and to thrive, leveraging the strengths to foster leadership development, workforce growth, and to build stronger partnerships. Over the last 20 years, I've served in so many different roles and capacities, supporting healthcare systems and health departments, convening partners to develop goals and objectives that align with the central vision to improve health outcomes for their communities. I have a unique background in infection prevention and control, working with the military to manage many programs and prepare for contingency operations. Through growth in my career and in life, one of the most valuable lessons I've learned, and its critical importance of self-awareness, understanding how my behaviors, culture, and perspective shape my beliefs and how these intersect with health and well-being. And today, Perfect Day will be exploring how health inequities or inequities within healthcare and applying social behavioral lens. With that being said, I'm going to pass it back over to Nia to kick us off with the overview for the webinar.
Thanks, Karina. So if you're tuning in through this event platform, the bottom of your screen should look something like this. So during today's session, feel free to use the chat feature to connect with each other, respond to our questions, and share any thoughts that you come up with during the webinar. And if you have questions for us, feel free to drop them in the Q&A tab. That's where we'll be pulling questions, and we'll do our best to answer as many as we can towards the end. Then you'll also see the resource tab a little bit further to your right, and this is where you can find your workbook for today's session. Once this session wraps up today, you can also head back to the home page to register for any of our upcoming webinar series that we're about to go over. So again, we want to welcome you to the NNPHI Advancing Infection Prevention and Control, a public health approach to bridging gaps and addressing inequalities webinar series. The series will explore critical issues surrounding infection prevention and control and the public health workforce, and how public health efforts can bridge gaps and reduce health inequalities. So to quickly recap, in webinar 1, we explored the evolving trends in the infection prevention and control workforce, focusing on the growing demand for specialized skills, training gaps, and the critical role NPH trained professionals play in shaping the future of IPC. We also discussed strategies to strengthen IPC education and enhance workforce development through interdisciplinary collaboration. So we'll talk a little more about what you can expect from today's webinar next, but we also want to remind you, don't forget to register for our upcoming webinars. On April 24th, we'll shift our attention to the role of infection preventionists, and our final session is scheduled for May 29th, and we will focus on essential interpersonal skills for IPC. So we'd also like to thank the Climate and Crisis Prevention Portfolio and Convenings Portfolio at the National Network of Public Health Institutes for organizing this event. If you haven't already, please register for the remaining webinars to learn more. So here's our agenda for today's webinar. We'll start with our learning objectives, and then Karina will present an overview of infection prevention and control in public health. We'll also cover identifying key inequities, in IPC, applying social and behavioral science theories to IPC. We'll also be addressing systemic and structural barriers and strategies for bridging gaps in IPC. And throughout the webinar, we'll have some polling and interactive discussion. So we're excited to engage with you and hear your thoughts. Then we'll wrap it up with a brief summary of today's session, and we'll give you the opportunity to share your thoughts and provide feedback throughout our evaluation. through an evaluation link. And so at the end, we'll have time for Q&A, and we look forward to answering any questions you may have. So throughout the webinar, feel free to use your workbook and reflect and take notes. All right, so before we dive in, let's quickly go over our learning objectives for today's session. By the end of today's webinar, you'll be able to define key inequities in IPC within healthcare settings, including disparities in access, outcomes, and resources. You'll be able to examine social determinants of health that contribute to the inequities in IPC and infection-related health outcomes. You'll be able to assess how structural and systemic barriers impact IPC implementation and effectiveness in underserved communities. The opportunity to develop strategies for the public health workforce to address disparities and improve equitable IPC practices. And you'll be able to apply social and behavioral sciences theories to IPC workforce training and intervention design. So let's get started. To kick things off, we will have our first poll question of the day. So we're going to be using Mentimeter for this one. To participate, just scan the QR code on your screen using your phone or tablet's camera. And once you scan it, a link will pop up. You can go ahead and tap that link, and the poll question should appear automatically. And then you'll be able to type in your response to let us know your thoughts. So the question for today is, in one word, what fuels your passion for public health or IPC? And I think it's pretty cool. We can all see the answers rolling in. So we look forward to seeing your responses. All right. Equity, education, community collaboration, problem solving, community compassion, prevention, helping, equity. All right, so far we've got 23 responses. We'll give it just a couple more seconds in case some other folks are trying to type in their answers. But I see we have some consistency here. We're all feeling the same about the work that we're doing and the passion for us doing it. This is awesome. It is so inspiring to see what drives your personal missions and the reasons behind the work you're doing to support the communities that you serve. Thank you all for sharing your thoughts with us. And now I'll pass the mic back to Karina.
Yes, thank you for participating. So today we'll be examining infection prevention and control through a social and behavioral science perspective. And with this lens, it helps us understand how individuals and collective behaviors interact with healthcare systems and influence infection risk and outcomes. For example, adherence to hand hygiene protocols, which is a fundamental IPC measure, can be shaped by workplace norms or access to resources like soap and sanitizer. Recognizing these behavioral dynamics is key to designing effective and inclusive interventions. So when discussing health equity, the focus is on providing fair and just opportunities for everyone to achieve optimal health. And health equity involves addressing systemic barriers and social determinants of health, including but not limiting to factors such as income, education, and access to healthcare. Hospital-associated infections highlight the intersection of inequities and behaviors in healthcare. And HAIs are preventable infections that are or can be acquired during a hospital stay. Some of the ones I may reference during today are central line associated bloodstream infections or CLABSIs, CODIs or catheter associated urinary tract infections. Systemic inequities like under-resourced hospitals often hinder effective IPC measures, while behavioral barriers such as distrust in healthcare systems can also complicate compliance. But together, these concepts emphasize the significance of adopting a holistic approach to infection prevention and control, which requires tailoring interventions to the unique needs of populations, because there is no one-size-fits-all approach. So as healthcare professionals, it's really vital for us to understand and clearly explain the difference between equality and equity and how inequities shape health outcomes. So equality provides everyone with the same resources, regardless of individual needs. While equity, on the other hand, ensures that everyone has a fair and just opportunity to achieve optimal health by addressing specific barriers and tailoring solutions to meet diverse needs. For example, I identify as a disabled veteran. So if my healthcare facility offered disabled parking passes to all employees who identified as having a disability, this will be equality, providing the same for everyone. However, equity would involve understanding the unique needs of each individual, such as physical or mental limitations, if any, and ensuring that appropriate accommodations are provided. And this tailored approach allows us to address specific needs and foster that meaningful access. Achieving health equity means acknowledging those diverse experiences that shape individuals seeking healthcare. Considering how cultural factors such as spirituality, for instance, for many women of color influence health practices and decisions. By embracing these holistic perspectives, we can create interventions that are not only inclusive, but are also impactful. And failure to recognize these distinctions can lead to that one-size-fits-all strategies that overlook the complexities of our human experiences and that often intersect and amplify challenges that are often overlooked in some and underserved communities. So building strategies that account for that intersectionality enables us to address root causes and reduce disparities effectively. Health equity is like finding the right size bike, as you can see on this image. It demands that tailored solution that addresses individual circumstances, removes barriers, and opens pathways to well-being. It begins with listening and learning, valuing each person's unique story to ensure care is personalized, inclusive, and respectful. So why does equity matter in infection prevention and control? So here's a snapshot of just some important statistics that dive further into that we'll talk about further in this webinar. So IPC is really a cornerstone of patient and healthcare worker safety, and it's crucial for reducing hospital-associated infections. Effective IPC programs have the potential to reduce HAIs by up to 70%, significantly preventing harm that would otherwise be avoidable. Despite this, access to IPC resources is not equitable across all communities. The financial burden of HAIs is immense as well, costing the US healthcare system an estimated $25 to $45 billion annually. And this strain on resources highlights the urgency of implementing IPC measures. Yet systemic inequities that are rooted in structural barriers compound these challenges. Research reveals that Black, Hispanic, and Indigenous individuals seeking care receive worse care in 35 to 40% of quality measures, demonstrating that disparities that directly affect their health outcomes. And these inequities extend to HAIs. Study has shown that marginalized communities face disproportionately higher rates of HAIs. For example, Asian and Hispanic individuals seeking care experience significantly higher rates of catheter-associated urinary tract infections. So such disparities are driven by just a combination of socioeconomic factors or gaps in training and resources and barriers. So while inequities in infection prevention and control, broadly impact people that are seeking care as well as healthcare facilities and personnel, they really manifest differently across healthcare settings due to systemic and structural barriers. So let's explore some of those challenges and practices, especially in some underserved communities that are slightly different. So disparities in access to resources, for instance, in underfunded healthcare facilities, particularly those that are safety net hospitals, essential prevention and safety supplies such as PPE, for instance, or sterilization equipment and isolation units are often scarce. But in contrast, private and well-funded hospitals have robust programs, creating disparities in those infection prevention capabilities. in rural healthcare settings historically have faced additional hurdles such as shortages of trained professionals and limited diagnostic tools, which lead to delayed outbreak resources and higher infection rates compared to urban facilities. In some long-term care facilities, including nursing homes, are particularly vulnerable populations. During COVID-19 pandemic, many of these facilities struggled with understaffing and inadequate IPC protocols, which resulted in devastating infection outbreaks. And also, we saw in the news a lot of resulted in restricting visitations and creating that social isolation. So disparities in infection-related health outcomes, some studies have shown against minority serving hospitals report significantly higher rates of associated infections like bloodstream infections or MRSA or ventilator-associated pneumonia. And these disparities underscore those systemic issues in IPC implementation and funding. In some of the more of the resource limited hospitals, restricted access to antibiotics or contributes to rising antimicrobial resistant rates. And without sufficient prevention measures, resistant infections are even harder to contain, especially in underserved communities. So during our last webinar, we discussed some of those workforce gaps in IPC. If anybody have joined those, you may have heard some of those that impacted retention, hiring, and workforce capacity. Some of you may be experiencing some of those right now. So we know that, in IPC, a well-trained professional in the workforce is critical. But in some of those safety net hospitals and rural facilities, that lack of that diverse skill set, such as infection preventionists or epidemiologists, biologists, this shortage can impact their ability to prevent, track, and respond to outbreaks efficiently. Even when there's protocols in place, not having the consistent training, like hand hygiene or PPE usage, can exacerbate those infection risks. And since the pandemic, studies have reported high workloads and burnout among healthcare workers. I'm sure you've heard this word quite a bit. So which can result in decreased compliance with IPC measures, raising infection risk for both patients and staff. So thinking about your own workplace, what measures are in place to support staff and mitigate burnout? And how are you taking care and advocating for yourself as well as your colleagues? I am a firm believer that when you take care of your people, they will take care of the mission. And addressing these inequities requires a multifaceted approach, investing in resources for underfunded facilities and improving workforce training and staffing and implementing equitable IPC policies. By tackling these disparities, we can create a safer and more equitable healthcare system for everyone. So what are some potential drivers of inequities in underserved communities? So I highlighted a few statistics earlier regarding minority serving hospitals and systemic barriers such as underfunding and resource limitations that lead to higher rates of healthcare associated infections. But a narrative review of racial and ethnic inequities in healthcare associated infections made an impactful statement, emphasizing that it isn't just about individual hospitals. It's about a broader system that has historically underfunded healthcare institutes that serve communities of color. And this research goes to highlight structural racism as a key factor driving these inequities, contributing to worse infection outcomes for marginalized communities, and identifying proposed actions to mitigate through interpersonal, community, and policy level interventions. At an interpersonal level, unconscious bias, such as a false belief that Black individuals feel less pain, can result in inadequate post-operative care, leading to complications like pneumonia. To address this, bias interventions must go beyond the surface level training and encourage self-reflection to recognize and mitigate bias in care. At a community level, adverse social determinants of health, such as poverty or limited access to resource, contributed to those higher rates of HIIs in marginalized communities. So by incorporating care coordination and addressing unmet social needs during routine visits, such as connecting patients to food or housing resources, can improve outcomes. For example, during my work in a mobile clinic, we assessed each individual's unmet non-medical needs and offered resources, as well as referrals through social network platforms to community partners. And at a policy level, safety net hospitals, which serve higher proportions of racial and ethnic minorities, often face underfunding and discriminatory reimbursement practices. And with these financial hardships, reduce prevention measures and exacerbate those health inequities. Conducting research and advocating for policy reforms are crucial steps towards addressing these systemic issues. But starting at the local level, utilizing evidence-based data, collecting at a local level and researching trends can garner support. So understanding the potential drivers of inequities provides that valuable insight into the experiences of often overlooked and underserved communities. And these insights can guide and develop multi-level strategies to address these barriers. So before we dive into social determinants of health, I'm going to pass it back over to Nia for a poll question.
Thank you, Karina. All right, now I think we're ready to reflect on some of the barriers we've encountered in our own individual roles. So for our second poll question, we'll also be using Mentimeter. So to participate, simply scan your QR code, the QR code on your screen using your phone or tablet. And once you scan, a link will pop up and you just tap the link and a poll question should appear automatically on your screen. So our second poll question is, in your experience, what is the most significant barrier to equitable infection prevention and control practices in healthcare settings? This could be anything from lack of funding, workforce shortages, limited training, cultural or language barriers, or something else based on your own experience. I see some responses are coming in already. Thank you so much. I see funding and costs so far. I'll give you all just a few seconds to respond. And, oh, okay, we have hiring preferences, lack of training, knowledge gaps. Okay. I'll give you all just a few more seconds to put in your responses. I love watching everything come live. I don't know about you all, it is pretty entertaining, but also nice to see that we actually have some of our similar challenges that we're experiencing. Misinformation, personnel turnover, shortened staffing. Yeah. We're all dealing with some of the similar things. 1 to 23 responses, so I think that's pretty good. So thank you everyone for participating and sharing your personal experiences with barriers to equitable IPC practices. These insights are actually very valuable and remind us of the challenges that we face and we're often encountered. But as we move forward, let's keep these barriers in mind and think about how we can address them collectively, whether through policy, training, or building stronger cross-sector partnerships. So I'll pass the mic back over to Karina. Thanks, guys.
Yes, thank you. It does look like there's a lot of funding issues within the group and a big concern overall. So thank you for participating. So I have a question for you all, and this is based off of my recent experience. So many of you may have any of you ever visited another country? And the reason why I ask this it is really because I recently had an experience. My children just went to Panama, and during our travels, they really noticed some differences for the first time, in infrastructure, quality, or access to stores, availability of resources from one neighborhood to the next. We stayed in a very rural area near the beach. And so public transit was used widely, but sidewalks were sparse and some of the roads were undeveloped. But what stood out the most to my family, though, was the language barrier and the frustration trying to speak, understand, and to connect with others. And this experience really reinforced the importance of language, culture, and how social determinants of health or non-medical factors like income, education, housing, and language shape people's ability to thrive. And in my experience conducting, health assessments and implementation strategies for health institutions, some of those barriers to care that are consistent around the nation include trust, culture, language. Humans want to be heard, seen, and valued. Language, education, and health literacy matters in health outcomes, and miscommunication due to those language barriers creates a significant healthcare challenges. According to the World Health Organization's lower education levels directly correlate with poor compliance to infection prevention measures due to the lack of understanding. Some of the impacts have been limited, those that are limited English proficiency patients often face longer emergency room visits or extended hospital stays and delayed access to care. Some also studies have shown that pediatric patients that are limited English proficiency experience higher rates of central line associated bloodstream infections. With over 80 million adult Americans having low health literacy, how does your organization ensure education materials and patient communications are accessible and easy to understand? In addition to language, education, as well as health literacy, historical mistrust in healthcare systems continues to influence health behaviors and perceptions among racially and ethnically minoritized populations. And recognizing that these systemic barriers persist across generations, how can we foster trust in daily interactions with patients and create a culture within healthcare facilities that prioritizes inclusivity and equity? So social determinants of health are very powerful forces shaping healthcare access outcomes, as well as infection prevention and control practices across diverse populations. And recognizing how these factors intersect is really crucial in driving meaningful change. And by acknowledging those systemic challenges, we can begin to design equitable strategies to ensure safe and effective care for all. And in addressing social determinants of health, again, they do improve health. And here are some statistics that show. So one of the studies by the NCBI, study on infection prevention and control and health equity, provides valuable insight on how addressing social determinants of health can lead to significant improvements in infection prevention. And the reason why I show this is is to ensure that, anybody who you're working with and partnering with, Nia mentioned partnerships and building those collaborations that may intend to support with some of that funding gaps that you may have. But in doing so is making sure you're aligning on the same page in understanding what social determinants of health are, what health equity is, so that you guys can move forward and aligning those goals and objectives. But from this study, what we saw here, and some of the improvements is in rural and underserved communities that often face greater challenges. This population, such as American Indian and Alaska Native, have faced disproportionate access to care and infrastructure, which resulted in higher associated infection rates. And through the study, targeted efforts to improve housing conditions and healthcare access have been shown to reduce HAIs by as much as 30% in those certain communities where overcrowding or unsanitary living conditions. Improving these living conditions and healthcare access also results in 35% decrease in catheter-associated urinary tract infections, in which Asian and Hispanic individuals have experienced significantly higher rates compared to non-Hispanic white individuals. And so ensuring consistency through hand hygiene of health professionals significantly lowers the risk of these infections and improve patient safety. The study also proved and showed that comprehensive hand hygiene education and training boosted compliance among healthcare workers by 25%. So in addition to standardized infection control practices, led to a 40% reduction in central line associated bloodstream infections. So through regular audits and feedback mechanisms, ensuring consistent applications of these practices all supported improvements in outcomes. So having explored some of these, the role, of social determinants of health and shaping IPC outcomes, let's now examine and show you a Chicago-based initiative that was successful at improving health equity and reducing disparities. And this example may inspire some ideas for implementing similar strategies within your own community. So the Healthy Chicago 2.0, it was a citywide initiative that was launched in 2016 by the Chicago Department of Public Health and was designed to reduce health disparities and create equitable access to healthcare resources for all of its residents. And the initiative focused on four key strategies. So improving access to healthcare, enhancing education and awareness, investing in environmental health, as well as fostering community engagement. And in improving access to healthcare, the Healthy Chicago expanded healthcare services to underserved areas by ensuring that communities with the greatest need received resources necessary for effective infection prevention and control. This included increasing the availability of clinics and healthcare providers in these certain neighborhoods. They also enhanced education and awareness through this initiative by conducting community-based education programs to raise awareness about infection prevention and control and health equity. And these programs empowered residents with the knowledge about infection prevention practices, such as hand hygiene, vaccination, and tailored to their specific needs, as well as the cultural context. They invested in environmental health, recognizing the role of housing and sanitation in health outcomes. So Healthy Chicago prioritized improving housing conditions and access to hygiene facilities. And this effort addressed one of the root causes of infection spread in overcrowded and unstable living environments. Fostering community engagement, this initiative actively involved community members in the health decision-making process by encouraging participation from residents, as well as faith-based organizations and local leaders. The Healthy Chicago ensured that solutions were culturally appropriate and aligned with the community needs. So the impact that this initiative had resulted in a 20% reduction in infection rates in that targeted communities and improved the overall health outcomes driven by better access to healthcare and enhanced living conditions. Some of the other key takeaways from this initiative demonstrate that by addressing some of those systemic and structural barriers requires a comprehensive and a community-driven approach. And by focusing on access and education, environmental health, as well as engagement, the initiative created a sustainable improvements in health equity and infection prevention. So reflecting on this initiative, it's clear that tackling systemic barriers requires understanding the social and behavioral factors driving health disparities. But before we dive into social and behavioral science frameworks, I'm going to turn it over to Nia so we can go through a workbook problem-solving activity.
Thank you, Karina. So we're going to shift gears and do a little self-reflection. If you haven't already, feel free to download the workbook via your reference tab at the bottom of your screen. And so once you download it, you can jump to page 2, and there you'll find the page titled Let's Problem Solve. So our question for you to reflect on, we'll give you about 2 minutes, is to think about if you're tasked with designing a health literacy intervention for a person receiving healthcare with low health literacy. How would you tailor your communication strategy to effectively support this person in understanding and managing their health? You should be able to type in the PDF form of the workbook. So feel free to take a few minutes to kind of reflect, type your thoughts there. And after, we'll come back together. And I'd like, if you want, to share a few of your thoughts and what you've come up with in the chat with us. So I will start the timer to give us just about a minute or two. And in case you might have just joined, we are working on a workbook activity. So with this activity, we're asking if you can download your workbook via the reference tab on your screen. And once you download it, you can jump to page 2. where you'll find a page titled Let's Problem Solve. And so the question for you to reflect on for the next minute or so is you are tasked with designing a health literacy intervention for a person receiving healthcare for low health literacy or with low health literacy, sorry. How would you tailor your communication strategy to effectively support this person in understanding and managing their health? And again, we'll have about another minute for you all to reflect and think independently. There is a free form text right under that prompt there, and we'll come back together in about a minute for you to share your quick thoughts if you would like in the chat with us. We have 5 more seconds. And then I will ask if you all would like to share your thoughts in the chat with us. All right. So again, in case you missed it, our question was, you are tasked with designing a health literacy intervention for a person receiving healthcare with low health literacy. How would you tailor your communication strategy to effectively support this person in understanding and managing their health? If you would like to share what some of your independent reflection thoughts were, feel free to share your intervention method in the chat. And I'm going to try and check and see if I see any responses. I don't see anything yet. All right. Let us know if you would like in the chat what strategy you came up with based on what we've discussed so far. But while we're waiting, you guys can continue putting your thoughts in the chat. But for the sake of time, I'm going to for some reason, in the chat, I can't see anything in the chat. Not sure if you all are seeing the same error message, but thank you all for taking the time to reflect and share your thoughtful ideas. Um, each of you brings a unique perspective to how we can better support individuals with low health literacy. So these kinds of conversations and independent thinking are exactly what help us move forward and develop our theories to real world impact. Now, to build on this momentum, I'll pass the mic back to Karina, and she will give us, she'll guide us actually through how social and behavioral science theories can be applied to infection prevention and control practices, helping us to better understand behaviors and how we can use that knowledge to create more effective, equitable interventions. Karina?
Great, thank you. I see some of those comments coming in. Thank you so much for participating. And so let's look at some of the social and behavioral frameworks that exist. So what do you know about social and behavioral science, and why is it important in understanding human behavior? And how can it be utilized in infection control? So social and behavioral sciences examine how human behavior, social structures, and interactions influence health outcomes. And in healthcare, it plays a crucial role in understanding disease prevention and infection control by addressing factors like health behaviors, cultural norms, and social determinants of health that impact patient care and public health strategies. So by integrating these insights, healthcare providers can, design interventions that are more effective and tailored to diverse populations. And these are several of the frameworks I will discuss that will help identify barriers to health, promote behavioral change, and also improve communication strategies. What they do is it provide structured approaches to address challenges such as vaccine hesitancy or adherence to treatment plans or adoption of prevention measures. For instance, the health belief model is a framework that focuses on individual perspectives of health beliefs and benefits. It examines factors like perceived susceptibility, severity, benefits, and barriers to actions, along with cues to action and self-efficiency. The social cognitive theory emphasizes the role of observational learning, self-efficiency, and reciprocal interactions between personal, environment, and behavioral factors. And the theory of planned behavior links beliefs to behavior, focusing on three components: attitudes towards behavior, subjective norms, such as perceived social pressure, and perceived behavioral control, which is confidence in ability to perform the behaviors. So together, these frameworks offer powerful tools for developing tailored health interventions and enhancing infection prevention and control strategies. And we move beyond that one-size-fits-all approach. They ensure that IPC efforts are both evidence-based and culturally sensitive and effective in addressing underlying causes. So how are we applying these behavior models in IPC interventions? I'll give you a couple of techniques and things that you can consider. So in thinking about the health belief model, this model focuses on how individual beliefs and attitudes drive health behaviors. So applying this model to an IPC intervention, focusing on, promoting hand hygiene among healthcare workers, for instance, the perceived susceptibility and severity. Do healthcare workers feel at risk of spreading infections if they skip hand washing? It's one of the questions to ask. Or do they understand the potential harm to people seeking care if infections occur? So it's important to educate and highlight the consequences of infections, such as prolonged hospital stays or complications with this perceived susceptibility. And perceived benefits and barriers, some questions to think about are healthcare workers aware that proper hand hygiene drastically reduces infection rates? Are there practical obstacles like insufficient access to hand washing stations or time constraints during busy schedules? Highlighting the effectiveness of hand hygiene and addressing barriers are keys to implementation. Some of the cues to action for the social model is provide reminders or prompts, posters, reminders near the sink about hand washing. Self-efficiency is building the confidence, providing hands-on training sessions and reinforcement. And so under the social cognitive theory, this framework focuses on learning through observation and interactions. So this is between the personal and environment and behavioral factors. So if we looked at hand hygiene, how do we apply this? Well, the observational learning of this model is positive behaviors. So by observing peers or supervisors practicing in consistency, reciprocal determinism is highlighting that interaction between personal behavior and social environment. In the environmental factors, it's considering supportive environment, so ensuring hand hygiene resources are available. And self-efficiency is confidence. So how confident are individuals and getting regular feedback and positive reinforcement, staying motivated. So these frameworks provide some of the solid foundation for guiding, IPC interventions by addressing individual beliefs and thinking through how people are perceiving, their risk or benefits. So building on this, we'll now look at theory of planned behavior, and which explores a little bit more of some of those critical roles of intention, perceived control, and subjective norms. And I'll just give you a brief kind of overview of this study that was conducted, and show you how they use this methodology. So this is actually an applicable way to apply. So this study was conducted in an Australian hospital, and to look at the hand hygiene behavior among nurses, utilizing the theory of planned behavior. So it was examined during the 5 critical moments of patient care. And does anybody know what those, it's the World Health Organization identifies as the 5 key moments of hand hygiene are? There's before touching a patient, before clean or aseptic procedures, after body fluid exposure or risk, after touching a patient, after touching patient surroundings. So this evidence-based approach is designed to be logical and user-centered and adaptable to various healthcare settings. To better understand compliance drivers, there was focus groups conducted during this study and explored three different beliefs. First belief is behavioral beliefs. So nurses discussed the perceived advantages and disadvantages of hand hygiene. And questions included, what do we see as far as the benefits? The normative beliefs as far as centered around that social expectations and peer norms. Also control beliefs. So these explored barriers and facilitators to compliance, such as accessibility. So the study provided valuable insights into how to boost adherence to hand hygiene practices, um, including those three things. So these findings demonstrated how positive attitudes or supportive norms in addressing logical barriers can significantly enhance hand hygiene practices among healthcare providers, which is fostering a culture of safety and accountability. Now I'll pass it over to Nia if we have time for a poll. No, I'm looking at some time. We may have to move through this one.
Yeah, let's say we can go ahead and move
Okay.
on forward for the sake of time.
All right. So what are some strategies for public health workforce to address disparities and promote equitable infection prevention practices? So in 2020, in APIC, the Association of Professionals in Infection Control and Epidemiology, they convened a Health Inequities and Disparities Task Force. And the reason behind this was to create actionable recommendations to address systemic and structural inequities impacting marginalized communities. Suggestions to effectively bridge inequities in IPC, was to improve equity at starting with individuals, organizational, and at public health. And in order to do this, it required engagement from federal, state, and local levels, which was essential in aligning under evidence-based practices and state priorities, which can help bridge the gap and support that policy change. Several of those recommendations included surveillance and research, which initiate, research efforts focused on health equity to guide decision making, or analytical resources, expanding data resources to analyze inequities at a national level. And also local level, and then equity-focused policies. So embedding these policies within infection prevention policies and guidance to address some of those systemic disparities, and also including some of the expert support from healthcare facilities, so including different specialists, diverse backgrounds. So these approach, when aligned with evidence-based practices and culturally relevant interventions, strengthen public health efforts to embed health equity within policies. So moreover, they provide a foundation for navigating uncertainty during periods of significant change, ensuring resilience and adaptability in advancing equitable care. Before we wrap up today, I'd like to take a brief moment to look at an innovative solution that was with the use of AI. And it was a community level approach, a little similar to the Chicago 2.0, but as far as, addressing social determinants of health. But the way that this works is the RTI, it's a social risk adjustment model. And so the way that this worked, and it was, I believe it was implemented in Ohio. That's where the model it's called the social risk adjustment was piloted. And this is an AI-driven model that integrated neighborhood level social determinants of health to predict health outcomes and inform targeted interventions. So for example, the model helped identify at-risk communities based on factors like inadequate housing or limited healthcare access, which are also known to increase disparities in infection rates. On a large scale, policymakers, can use the RTI model to adjust healthcare performance metrics, ensuring fairness for providers, serving marginalized populations, and promoting equitable practices across the system. So thinking about your own organization, what innovative tools or strategies are being used within your own communities to address social determinants of health? Feel free to share any of those in the chat if you'd like. So but as we wrap up, and by addressing, embracing community-driven approaches, we, develop some targeted collaborative solutions that foster more equitable and resilient health systems. And health equity is never, again, that one size fits all endeavor. And it really demands that identifying systemic and structural barriers and addressing these specific social determinants of health and applying a human center and using some of those social behavioral skills. So to leverage our background. So I'm going to push this over to Nia for some questions, looking at our time, and to be mindful and see if we have any questions before we wrap up for today.
Thank you, Karina. So yeah, as Karina was saying, we'd love to hear your thoughts. We're opening the floor for questions now. So feel free to ask your questions in the Q&A tab at the bottom of your screen. And while we're waiting to hear your questions, you can also share your thoughts on how you think we can improve by sharing your feedback about today's webinar through our quick evaluation poll. So as you see on your screen, there's a QR code. That's another way that you can that is the key way to sharing your evaluation thoughts with us. And I will take a moment to check the Q&A poll here to see if there's any questions. I don't see any right now at this time. I'll go back and check the chat real quick. No, I don't see any questions. I'll give it just a few more minutes, but you guys can still put things in the chat as I continue. So I'll do a quick wrap up for today's webinar. So let's go over quickly what we've covered. We've identified key inequities and infection prevention and control within healthcare settings, including disparities in access, outcomes, and resources. We talked about social determinants of health, such as income, education, and healthcare access, and how they are the drivers of inequities and affect infection-related health outcomes. We also discussed how structural and systemic barriers impact the effectiveness of IPC in underserved communities. And while these challenges are significant, we've also identified strategies to address them, improving IPC practices and making them more equitable for everyone. One important takeaway for today, I think, is the value of applying the social and behavioral sciences theories, like the health belief model and the social cognitive theory, to guide IPC interventions. And these theories can really help shape better workforce training and interventions, ensuring that we address the root causes of inequities in IPC. So now it's time to reflect. How are you thinking about applying what we've learned today? Do you plan to continue identifying barriers, developing strategies, and using insights from the SBS model to make IPC practices accessible for all? I think this would be a great opportunity to jot that down in your workbook and share your thoughts. And I forgot to share as well what's in the workbook. So inside, you'll find a few extra reflection prompts to consider for today's webinar. We've also included a solid list of resources to support you on your journey in infection and prevention control and public health. That includes continuing education opportunities, public health job boards, on-demand webinars, and you can revisit those at any time. And there's so much more available in the workbook as well. I am checking the chat one more time to see if there's any questions. I don't see anything. All right. But last but not least, we'll put up the opportunity to share your thoughts with us again. Help us improve by sharing your feedback about today's webinar through our quick evaluation. So again, to participate, feel free to scan the QR code on the screen. I see there is a link available in the chat as well for you all if you would like to share your thoughts with us. And I see it's 12:58, so I'm going to try and wrap us up real quick. But we appreciate your time and look forward to your feedback. So don't forget to register for webinar 3, role of infection preventionist on April 24th, I'm sorry, April 24th from 12 p.m. Eastern Standard Time to 1 p.m. Eastern Standard Time. And while we move to show the references for today's training, Karina, do you have any last words that you'd like to share with us before we close out?
I just want to say thank you, everybody, for attending and for participating. Some great feedback and great information. And remember to lean on each other, have some grace for yourself, lean on one another, and find those people in your circle to give you strength through these times. Have a good one.
Thank you, Karina. I do see one question that asks, is all of this information on your website? And I see it was asked, the information for this webinar can be accessed on the webinar series homepage through CVents. Thank you all for your time and attention today, and we hope to see you on April 24th.